Hello, this is Dr Giza. I want to thank you for inviting me here, and I wish I could be in Milan. I want to thank Gordon and everybody here and allow me to talk about LisFranc ligamentous injuries. So my disclosures, obviously arthrex. So the ligamentous complex of the LisFranc, obviously there's three main ligaments: dorsal, plantar, and the interosseous. Dorsal is the weakest, plantar is there, and then the interosseous is the one that we focus on for the internal brace. So with these patients come in, they'll have ecchymoses. This is one of my favorite exams where you hold the 2, 3, 4 MTP joints in the first and push down on the second, and they'll have pain. And this is for the subtle athlete who comes in, but this is a intraoperative photo looking at that, and you can see this is, you can see that there's a piano key sign, meaning that it moves up and down. And in terms of imaging, it's easy peasy when you have the diastasis on weight-bearing imaging, which we always get, but it isn't always. And there was a study many years ago kind of showed that if you have second and third TMT plantar instability, that there will be some overlap and it won't necessarily have a big diastasis. So we'll get a CT scan whenever there's comminution, and that's obvious. But Rakin and others really showed that MRI for these ligamentous injuries, particularly ones who are going to use the internal brace, is the best. And he looked at 21 feet and showed the intraoperative predictability, and it's high. And other studies have shown that, such as this. Chris Krul and I, my partner, showed, and we just wanted to compare uninjured patients to injured patients. And obviously, if you see a lot of edema, even if it doesn't look like it's completely torn, there's probably a grade 3 injury. So when you have this, do you fix this one? And usually I'd like to take it to the operating room and just double check. In a stress radiograph, and this was one from Chris Krulin, showing this subtle instability. And so that's often missed. And then this gives you the opportunity to see if there's any intercuneiform instability. So it's a spectrum, okay? So, how do we treat these days? I mean, we know that LisFranc himself was conscripted into Napoleon's army. He was a gynecologist by trade, and he just described the anatomy in that area. But, we have our traumatologists and our other general orthopedic surgeons. And so these aren't all the same. So if you look back at what Chris Coetzee had done, and this is a very admirable study. Chris is a good friend of all of us, as we know. And, back then they were like looking at, hey, ORIF versus fusion, but this was the ORIF. It was just shoving some, synthy screws across it. All we had was large frag or small frag screws back then. And is this better? Well, no, because they probably all got arthritis. And so there's been a number of studies looking at, percutaneous ORIF versus primary, arthrodesis, and that there wasn't a huge difference. And then there's been a change in the literature over time. And if you exclude, hardware removal, et cetera, that really there weren't a higher rate of reoperation. And then the return for athletes, certainly there's been some traction of saying, hey, in the military, if you fuse these guys right away, but if you don't, and you do, internal fixation, that there may be a difference. And there was a cadaver study done a long ago for Nam Pichabi, who's a good friend of mine from Texas, and he showed that even there wasn't a huge difference between screw fixation and using back then the mini tightrope. So can we recommend non-operative treatment? And this was a study from England where they looked at patients with minimally displaced LisFranc injuries. And even with 6 to 8 weeks non-weight bearing, if you followed them up at a year, those non-weight bearing patients had, displacement. So eventually, maybe some of them are still going to get arthritis. Now, of course, this high energy LisFranc, how do we fix these? We're going to fuse this. I'm going to get somebody like this. This is not a LisFranc InternalBrace case. Fuse, or you get the older patient who comes in, she was about 8 weeks out. Certainly, she's better served with a fusion. But for our athletes and our younger patients, what do we do in 2024? And so, as I mentioned earlier, there was the tightrope, which is a great thing, but we looked at our results, early on, and we saw that there was some creep in the tightrope. And of course, with the InternalBrace, there's a much better fixation. And then there's, collagen ingrowth. And then since then, we've kind of taken it to the next level with, putting it over the top. And what I mean by that is doing some, fixation of LisFranc itself, but then also fixing the inner cuneiform and giving this construct a little bit more stability. So, we're in the early days of really good literature, but obviously we've started off, and the concept is that you're putting it through the interosseous membrane, interosseous ligament, which is pivotal to making sure this fixation is solid. We did some benchtop data years ago, looking at just the InternalBrace itself versus a tightrope versus a screw on one of our Instron machines here in UC Davis, and obviously the IB was stronger than a tightrope, but it didn't break like a screw did. And then I got to give props to my colleague Mike Ionardi, who's a rising star at Penn State, and he just kind of took this to the next level, saying, what if we put this over the top? And he looked for the rationale behind the ligamentous LisFranc InternalBrace repair. So he did this very elegant study, and I don't have all the slides in here, but he did use a cafeteria tray as part of it. But they have this very elegant biomechanics lab, but they needed something very flat, and you can see that there. And they were able to reproduce the LisFranc injury, and then they also showed that doing it versus screws, and that you could reproduce it, and that the over-the-top actually supplemented the InternalBrace repair. And so that was published, and then the follow-up study, which was published in the American Journal of Sports Medicine just a couple of years ago, was 2 screws versus LisFranc, because obviously our trauma colleagues are always like, I just do 2 percutaneous screws, and that's all you need. And the LisFranc InternalBrace over the top construct is just as strong, 1,400 newtons, but no failures. And in the screw group, a couple of them broke. And we all know that's the kiss of death. If you have an athlete and you have a broken screw, that's no fun. So indications are everything I talked about, these acute LisFrancs, these chronic or subchronic, 6, 8, 10 weeks out, where they didn't think they had one, but they have a positive piano key sign. And obviously this is not an indication for Charcot or folks with peripheral vascular disease. So over the top is how we do it now. I like to make an incision on the lateral border of the second, between the second and third TMTs, and this allows you to really clear out the LisFranc. I don't favor the old-fashioned AO incision straight over the top. You can see that. You can see right in the joint, and then it allows you to do a medial incision if you need to. This allows you to test for intercuneiform instability. You can see right into the joint, and you reduce it. The nice thing about this technique is there's a 1.6 to 1.1 millimeter passing wire, so that's all that you're putting through the center of the the intermediate membrane and ligament. So you can see that, and then you want to make sure that you pass it plantar to the tibialis anterior tendon. So that goes through, and then you pull the lesser part of the wire through, and then you retrograde into the medial cuneiform. And there was a lot of research behind like size of the medial cuneiform, and that's why it's a 13 millimeter drill. And then you pull it through, and it's fairly easy to pull through. You make sure the buttons on the kind of dorsolateral aspect of the second metatarsal, and then you put the interference screw here. You got to make sure somebody is pulling, with maximal force. And then now we bring it over the top. So you have to extend your medial excision in a little bit, but use common sense. You got to make sure you get underneath the tibialis anterior and underneath the neurovascular bundle. And then you just pull it through. And then you drill, and with maximal tension, you put the internal brace up and over the top. And there's the pre. You can see that instability, post, and even stabilizes the second TMT joint. So that's the final construct. Looks good. This was one of our professional soccer players here in Sacramento. And you can see the edema all the way through. And then he got back at about 4 months. And then when he was retiring, we got an exit MRI at 12 months, and you can see the reconstitution of the ligament there. My friends in Chile and in Brazil have looked at doing this for multiple folks because they don't have the opportunity necessarily all the time to take out hardware, and they showed that you could do a multi-ligamentous reconstruction. One thing, where's the whys? This is my little schematic kind of showing that, if you have really bad second TMT instability, you should bridge plate, but then also put the LisFranc internal brace underneath. You can see that there, and that was someone also with first TMT instability. But here it is. You can still do second TMT plating. This was a professional mountain biker here in California. We did that, and then we took his plate out at about 4 months, and he was back doing his thing. So quick overview of our short-term clinical outcomes. We partner with Penn State, with Mike Ionardi in the group. We had 15 patients, 8 isolated ligamentous LisFrancs, and then 7 who had intercuneiform instability, which needed an extra limb of fixation and or bridge plating. So, we had just over a year and a half follow-up. Average time to weight bearing was 6 weeks. Average return to work and sport was just over 3 months. So we had no major complications, and just a little bit of hypersensitivity, little bursitis on the medial cuneiform. So I would encourage you to use this technique, and wish I could be there in Milan with everybody. Apologies I can't, but I look forward to many great conversations and InternalBrace collaborations in the future. Thank you so much.